Okay, guys, let's get started then. So I'm just going to quickly share my screen with you guys and also introduce myself at the same time. So my name is Sheba. I am a hospital pharmacist currently working in Scotland, and I am Pharmacy Foundations, and I'll be leading today's session with you. So I'm just going to share my slides with you just now, and then we can get the ball rolling. Firstly, can everyone just confirm that you are seeing my slides? Hang on a second, let me just expand. Can everyone see my slides? Just confirm in the chat for me before I get started. Perfect, thank you so much. Amazing. So before I get started with our session today, which is going to be focusing on skin, eyes, and ENT, I'm going to launch a quick poll just asking about how many of you guys have actually seen the webinar and here just to ask any follow-up questions, or whether this is your completely new time watching this video and having this session with me. So, oopsie, hang on a second, I'll also do that for you just now. So I'm just going to launch this video, watch the video, which is the webinar with the recorded version of this session that we're doing today. So if you all can kindly register your responses. And in 5, 4, 3, 2, 1. So about 33%. So one person has watched the video, where it whips, changed to 2. 2 have watched the video, 2 haven't. Okay. Just sharing that to you as well. Okay, so we've got a split, yeah. So that's quite helpful for me to know, just so I can drive the session more to what you guys would like. So some of you have watched the session before, which is great. You can ask questions that you might have wanted to ask at the time, but weren't able to. And some of you, this is completely new. So the way the session's going to work is I'm not able to cover the whole of the content of the webinar, because there is just a sheer volume of it. But what I'm going to try and do is share snippets of each part of it to give you a flavour as to what sort of things you might need to know for the exam. So hopefully that will help for those of you who haven't already seen or had a glimpse of the session. For those of you that have already seen the session, please feel free to pop in your questions into the chat function at various points. I'll try and keep an eye on it and answer them throughout, but there will be an opportunity to ask questions at the end as well if you feel more comfortable doing that as well. So without further ado, I'm going to get started, and here we are. So as I've mentioned, I work for an organisation called Pharmacy Foundations. Now, we do quite a lot of stuff. We are mainly here to help the development of pharmacists at all stages, but we obviously do other training material for various other healthcare professionals as well. And as we say, we're on this journey to try and help you at each stage of your career, whether that's from undergraduate to foundation year training to postgraduate as well. So there's plenty of opportunities to get involved with us as a foundation. I myself used this organisation whilst I was revising for my own exam, and obviously I'm now here helping other people do the same. So it's a great organisation to be with, and it's a great organisation to learn from as well. Sorry, my mouse is not great. And again, we've got a variety of projects. So as you can see, there's different opportunities to get involved. We've got, for those of you that might be in primary care or hospital pharmacy, there's quite a few different courses that you can get involved in after your exam as well. And we're a big team. Obviously, that's me here. My name is Sheba, and I'm a clinical tutor at Pharmacy Foundations, but we've got other colleagues as well from various different backgrounds that are on the team. All the content that we develop is rigorously reviewed, and it's gets a second opinion, so there's nothing out there which we haven't already checked for you. And like I said, we're very diligent with the content that we produce, so we are there to help you guys, and we give the best material and the most top quality material for you to learn from as well. And we've got a few different platforms that we're available on for you to get in touch with us. So we've got Twitter, Facebook, as well as Instagram as well, if you're interested in connecting with either one of us on that. And then we also have a WhatsApp chat as well for those of you who are interested in joining our WhatsApp chats. And again, we've got a bit of direction there for anybody who is nearly about to sit the exam, etc. as well. So feel free to join in that as well. So without further ado, I'm going to get cracking with what I would like to get out of this session. So the first part of this is skin. So when I first recorded the session, this is the learning outcomes that I wanted everyone to get out of the session. So in terms of skin, we want to recall the different types of skin ailments that you might encounter in practice. Oops, sorry, I think it's running ahead of me, this. Might have clicked my mouse too many times. And then we also want to recognise the referral criteria associated with some of the common OTC complaints. We also want to recommend treatment options for common skin ailments as well. So in terms of the skin and the registration assessment, it's a low-weighted topic. So about 10% of the content of the exam will be based on this, okay? And the majority of clinical content and pages is going to be eczema and psoriasis. There's overlap with other sections of the BNF, so systemic management of skin infections, pruritus, psoriasis, androgenic alopecia. And you need to be able to recognise OTC skin presentations, conditions, or symptoms of a condition. And this may not always be able to be treated OTC, so you should be comfortable at referring as well. And it's an ideal topic for picture resources and calculations. So first of all, the layout of the drop-in session is going to be as follows. So I'm going to answer some of your emailed questions, which we have received from people that might have seen the webinar before. We're also going to look at some popular sections revisited. So that's what I'm going to do in this session. And then, ignore that part. And then your chat questions answered. So that's going to be anything that's answered through the chat itself. So first of all, in terms of your emailed questions, there were a couple, so I'm just going to quickly go through that just to give you a feel for what people have asked already. So there was a question asking, how much do we need to know about the different types of eczema? Now, in general, eczema or skin is a very big topic. I don't imagine that there will be lots of questions asking you about the variety or the etiology of all the eczemas. But specifically what we do expect in the GPHC exam is that there will be some sort of picture-related question or even an extended multiple choice question, which requires you to rule out some sort of condition. And namely, the eczemas that you will see in the community pharmacy setting would be atopic eczema, your allergic contact dermatitis eczema. These are the sort of main two types of eczema that you will see patients coming to the community pharmacy for. So it needs to be something that you should be well able to recognise as well. So remember, the GPHC exam is not just about passing, it's also about giving you the knowledge to carry forwards to your practice as well. So I would say those two main types of eczema are really important to be able to cover a bit of grounding with. And you would have known a bit about this in university as well, and through those of you that work. So those two main ones are really important to know about. But overall, for the exam, I would say you should be able to recognise some of the common skin conditions based on pictures alone. You should be able to have an idea of what treatments are available for those as well. So that would be my answer to this question. Second, what do we need to know about glaucoma? Because remember, we're covering skin, eyes, and ENT in this webinar. So another question was about glaucoma, and similarly, it's a big topic. The eyes section, there's quite a few different parts, but glaucoma is quite an important one. Now, I'm not saying that you'll face this in the community pharmacy setting. However, in terms of glaucoma, there are questions in the exam such as what treatment options are available, or it might be like a ruling out question where you need to know what treatment option is and what their mechanism of action is. You also might need to know about the drugs that may exacerbate glaucoma glaucoma, in which case, how do we avoid giving that treatment to that patient, especially if they're already on something for their glaucoma, and then you're recommending something else which may actually exacerbate their glaucoma. So you should have an idea of what drugs can and cannot cause glaucoma. And I'm going to cover this in a bit further detail in the section that comes with eyes as well. And then secondly, which resources can be used for skin stroke other images? Now, as part of your revision, I do recommend that you go out there and look at various types of skin pictures so that you have an idea as to what you can come to face with in the exam. But in terms of what to use for resources, DermNet is quite a good website to use because they use a lot of pictures for their resources. Also, NHS Inform is another common website which actually the GPHC may well just extract images from. So those two are my go-to websites, and those were the two that I used for my own exam. And I think in terms of how I got, because the resources that they use are more or less exactly the same that came up in the GPHC exam in terms of pictures. So I would say definitely use that. Sorry, which one was the second one? So I said derm.net and then NHS Inform in general. These are websites, if you search the specific skin condition that you're wanting to know about, they will come up with pictures. Okay, so that is those questions answered. Now I'm going to jump into skin straight away. So what do we actually need to know about skin? First of all, when somebody presents to you in the community pharmacy setting, these are the sort of questions that you need to be thinking about. First of all, number one, age. Think about their age. Epidemiology of skin conditions can vary with age. What's more common in a child versus what's more common in an adult are two different things. Second, we've got is site. So certain parts of the body are linked with different etiologies. Again, for example, e.g. warm, most areas ideal for fungal growth. So under the breast, for example, in the groin area, armpits, those are areas where you might notice more choice for fungal growth because of the environment in which the bacteria or the fungi find themselves. Next is number 3, number of lesions. So again, this will allow you to determine the extent of the problem and rule out certain etiologies, e.g. most bacterial infections are confined to a specific area. And obviously if they get worse, then you know that it's a problem. You know, you might need to refer depending on what it is. And then we've got characteristics. So the shape, the edge, the color, the secondary features, all of these will lead you to perform a wee differential diagnosis in your head. And then we've got number 5, distribution pattern. So again, eczema likely on the inside of joints, whereas psoriasis is likely on the outside. And then 6, associated symptoms. For example, is it itching? Is it painful? Is it causing them discomfort? Now, specifically, I'm going to focus on psoriasis because I think eczema is comfortable with. I think we've seen it so many times in the setting that I don't want to spend too much time on this, but psoriasis not so much. So for example, psoriasis is a systemic immune-mediated inflammatory skin disease, which typically has a chronic, relapsing, remitting course and may also involve nail and joint involvement. So you should know that already, that psoriasis is not a consistent thing that you see. There might be episodes where the patient is amazing, they're feeling good about themselves, there's nothing to worry about. And there might be episodes where something exacerbates that. And that's something that you just have to be aware of. It's something that you should know about its etiology. My mouse is just not playing right and it's turning out to be quite slow, sorry. So again, in terms of characteristics, there's epidermal thickening and scaling, and it will affect the extensor surfaces and the scalp. So when I say extensor surfaces, it usually means the elbows, the back of the knees, the kneecaps, etc. So all the sort of extensor surfaces. And scalp psoriasis itself can be sorry, I can't speak, affects 75 to 90% of sufferers itself. So most patients will have some sort of scalp psoriasis if they are diagnosed with the condition. And then treatment-wise, we've got a lot of different options. So initially, depending on what they present with, there will be topical treatment. So that may be phototherapy, emollients, vitamin D preparations, which is quite a common thing that's emerging nowadays. And then there's topical corticosteroids, salicylic acid, coal tar. So there's a variety of products to try before you go on to the systemic therapy, which is mainly with biological treatment or DMARDs, which are disease-modifying anti-rheumatic drugs. And it's mainly because it's an immune-mediated response that this psoriasis comes about with. So we're going to go through the treatment options through my patient, Tom. So this is our first case study. So case study 1. Tom is a 34-year-old web developer and also one of your regular patients. He comes into your pharmacy wanting some advice about a rash on his head, which has been on there for a few months on and off. Tom also informs you it previously calmed down with E45 treatment. However, recently this flare won't budge. So we've got a few treatments there in terms of past medical history and their medication that the patient is on as a result of that. And then you've also got a bit about his social history as well. Okay. So based on his presentation, what would you say Tom is likely to be suffering from? So any suggestions as to what you think this is? Obviously, it's kind of a giveaway, but hopefully the picture, if you saw that in the exam, what would your mind be thinking of? Any suggestions at all? So this is an example of scalp psoriasis, okay? I'm sorry. So likely to be suffering from scalp psoriasis. He has a past medical history of inflammatory bowel disease, and he also has hypertension, which predisposes him to developing psoriasis. So this is a good idea or a good opportunity to develop your understanding about what conditions can put you at risk of other conditions, okay? And then if I go back to the previous slide, this patient's got AF. Is there anything in his drug history that we are missing or we should be expecting this patient to be on? You can answer that in the chat function whilst I move ahead. Anticoagulation, perfect. Thank you, Sonia. So yes, exactly. Anticoagulation is something that you should be expecting this patient to be on. And if not, then why not? So in terms of treatment options, what do we have? So mainly think about non-advice first, like non-pharmaceutical advice. Smoking cessation is really important for any immune-mediated condition, specifically psoriasis and RA, rheumatoid arthritis. His BMI was raised as well, so weight loss program, reducing alcohol content, all of this would be helpful in general. But treatment-wise, we should recommend continuing emollients and also ask Tom to make a routine appointment with a prescriber. Now, we said it was a chronic relapsing remitting condition, but it is important that he gets seen to because it seems to be a condition that they've not necessarily diagnosed. So it's quite important that this is on the GP's radar. And the flare has lasted for a while, so it would be important to just refer. A non-urgent referral would be appropriate in this case. And then in terms of what would you expect Tom to be prescribed, as I've mentioned, it's at the moment that he's experiencing. So first line treatment would be a topical potent corticosteroid once a day for 4 weeks, okay? And if the above treatment was failing for Tom, what would be suggested next? Again, second line, an alternative formulation of topical steroids, such as, depends on the formulation that you prescribe, obviously, for the patient, but you can also combine that with topical agents to remove or soften adherent scales. So products with salicylic acid, oils, etc. would be appropriate. Now, in between each treatment, we do recommend waiting about 4 weeks before you change them as well. So that's another thing. And then third line is obviously vitamin D combined with steroids, and this is all mentioned in the BNF, so it's important to have a wee look at this. And then lastly, no response, very potent corticosteroid for 2 weeks, or coal tar, or refer, either way, but that's not really your call to take. So that's essentially the case study for Tom. Hopefully that was okay. But like I said, it's a big topic to consider, guys, and I would say that there is a lot to consider just for the exam. So I've mentioned those two websites at the bottom. NHS common skin conditions or NHS Inform. Either one will get you to those skin conditions. And then DermNet is really helpful as well for all those skin pictures. But then there is other reading that you should be doing, such as skin cancer diagnoses, sunburn and sunscreens, nappy rashes, all those sorts of things that you will be coming to face in the community pharmacy setting. And like I said, the exam does not discriminate between who's working in which sector, so you should know this irrespective of what sector you choose to work in. So hopefully that's okay so far. In terms of skin, obviously feel free to pop in any questions in the chat function. Now next is eyes. And again, in the registration assessment, sorry, let me just check. Do you offer any topic quizzes? So it depends on how far you are in your journey with us, Maria. So I think each our membership does contain case studies and quizzes. So that's something that you'll have to get in touch with the team for if you wanted that sort of information. But in this session, obviously, it's just whatever I offer to you. Hopefully that answers the question. So eyes, again, it's another low rated topic. So up to 10% of content in the exam may be focused on a low rated topic. And then there will be overlap with other sections of the BNF. So again, if you've known that, then you shouldn't be worrying too much about the eye topic itself. There will just be certain things that you need to know about. And then need to be able to recognize over-the-counter presentations. That's the big important one. And again, there will be pictures about this as well in the GPHC exam that you should be comfortable with. And there will be calculations as well, depending on drops, etc. So again, both these elements of the exam will be something that you should be confident with if they come up. So again, in terms of the learning outcomes of the session, this is what I suggested and expected if you had joined the webinar when you were seeing the recording, but this is what you should know for the exam as well. So optimal use of preparations, recall causative organisms, diagnose and manage ocular conditions, and also be able to know about the understand red flag symptoms and identify them. So what are red flag symptoms? So in terms of eyes, a lot of examples of red eyes in specific, but each red eye might be a different diagnosis in particular. So how are you going to be confident with your diagnosis, and how are you going to be confident with your referrals? So first of all, we are going to look at this mnemonic here, which is called punctum. So pain in the eye, unequal or misshapen pupils, neonatal sticky eye, ciliary injection, trauma to the eye, unable to see, so any visual problems, and then M is miserable towards light, so photophobia. These are the 7 points that you need to be aware of when you're looking at any sort of eye condition that you might be presented with in the community pharmacy setting. Again, very limited time, so I can't go through each and every one of them, but this should prompt you to look at each and every one of them if you already didn't know that these are red flag symptoms. In terms of case studies, we're going to go through one case study just to give you a flavour of things. So first of all, following on from the procedure, Mr. P calls your pharmacy and tells you that he has been prescribed the following eye preparation. So that's a list of preparations that this patient has been prescribed. He is a little confused as to how he should use or apply these eye drops. What advice would you give with regards to the use of the above? So it's a common question that you might be asked. So if you were wondering, you won't be asked these questions in the community pharmacy setting, think again. So this is a patient with multiple eye drops. How does he go about administering these? So think about the preparations. When you've got two different eye drop preparations that are used at the same time of day, then there can be a risk of dilution and overflow that may occur when one immediately follows the other. So you might not be giving the patient the best out of their treatment if they're consecutively putting each eye drop in, because it might just flow out straight away because of the tear production that's produced. So how would we go about this? To prevent dilution and overflow, you should leave at least 5 minutes between all preparations. And the interval may be extended when eye drops with a prolonged contact time are available, so such as gels and suspensions are used. This might lead to more retention time in the eye, so you might need to extend that interval. And eye ointment should also be applied after eye drops because they stay in the eye for longer. Eye drops. So first of all, instill one drop into the pocket so the pocket is just, if you pull your lid down, a pocket's formed, and that's your pocket. Formed by gently pulling down the lower eyelid and keeping the eye closed for as long as possible after application. Installation of more than one drop should be discouraged because of increased systemic side effects, but also overflow. And pressure should be applied to the lacrimal punctum. So this is the corner of your eye for at least a minute after applying eye drops, because there is a risk that it runs through your nasolacrimal duct, so it might overflow through your nose as a result. And then secondly, eye ointments. A small amount of eye ointment is applied similarly to eye drops. So again, you might just need to put a streak under in the pocket rather than an actual drop. And the ointment tends to melt rapidly, and blinking helps to spread it. And then eye ointments or oily eye drops should be avoided in contact lens wearers. So you would use unpreserved eye drops where possible. So your first question is, Mr. H has also read in an article that some medicines taken orally can affect contact lenses. He wants to be sure that his current medication regime is fine with this. So from the list of below, which one of Mr. H's drugs would not be fine to use whilst wearing contact lenses? So does anybody want to hazard a guess as to what the answer to this question might be? So someone has said option A, aspirin, and aspirin is correct. So well done. So aspirin actually can lead to irritation of contact lenses. Now, are we going to tell this patient to stop their aspirin? Absolutely not. It's just something to be aware about, okay? Obviously, if it becomes a problem for the patient, we don't outrightly tell patients to stop their medicines, but it gives you a feel for what sort of information you might need to know for the exam. And certain drugs which can colour your contact lenses would be something that you should know as well, because that's quite a common rule out question in the exam. Fabulous. So let's go with some glaucoma, ocular hypertension, true or false questions. So first of all, if a patient has glaucoma, is it always related to raised intraocular pressure? True or false? False. Exactly. So most commonly, it tends to be because of raised intraocular pressure, but it's not always due to intraocular pressure. So that is a common reason, but it's not the only reason. So that's just something to be aware of. Next is patient has type 2 diabetes mellitus. Does that increase their risk of possibly developing a condition called glaucoma? True or false? Fab. True, exactly. So this is about your knowledge of conditions, clinical conditions that can cause or increase the risk of another condition. So we know that diabetes mellitus in general can affect the major organs, the macrovascular system, the microvascular system. So someone with healthy eyes will be monitored regularly throughout their lifetime so that they can keep an eye on these symptoms, especially when intraocular pressure is not necessarily something that can be measured directly, etc. So that is true, exactly. So that's just a flavour of ocular hypertension and glaucoma. So these are the sort of things that you should be aware about and you should be comfortable answering yourself. And hopefully going into the exam, you should be able to get a feel for what would be appropriately asked in the exam. So sometimes quizzing yourself is great because you should be able to anticipate what sort of questions might come up in the exam. So I'm going to go with eyes now. So I've said red eyes. Before I give you the answer, what does this eye look like? Can anybody give me a diagnosis as to what's happened to this eye? And whether we're going to refer this patient? Is this serious? What's going to happen to this patient? So someone said scratched, someone said subcorneal hemorrhage. So it's a subconjunctival hemorrhage, okay? And this can happen due to a variety of reasons. Raised blood pressure could be one of them. It could be due to heavy weight that's been picked up. It could be due to pressure in the eye as a result of bending down for too long, etc. A variety of reasons. In terms of whether I would refer this patient, nope, I'm not concerned about this patient at all. It's very self-limiting, and obviously, if it was causing some of those other red flag symptoms, then yes, refer. But if it's simply that, patient can see fine, patient's not photophobic, absolutely fine. I would leave this patient alone and just give them reassurance that it's quite normal to happen. But obviously, if it kept on repetitively happening, perhaps a wee referral to the optician would be okay. But as a general thing, if I was to just see this on its own, I wouldn't be too concerned. So you can see how something that can't speak again, something like this, if it came up in the exam, there may be people swithering between referral and not. And one of the feedbacks that we get from the GPHC exam every year is that there are inappropriate referrals. So be confident with what you can and cannot refer to the GP, to the optician. So yeah, subconjunctival hemorrhage. So next is ENT and the registration assessment. So again, it's another low-rated topic. This whole section is a low-rated topic. But as I mentioned, there are things that you might not know which might end up losing the marks that you would have rightfully earned if you had just known a bit more about this topic. So over-the-counter remedies are available for alleviation of symptoms and in some cases for the treatment of conditions. So that's something that we should be aware of, what treatment options are available, what can we refer and what we cannot refer. And again, there's an overlap with other chapters, specifically when it comes to infections and the CNS pain and sensory involvement. And then again, similar to skin, this chapter is ideal for picture resources. In terms of the learning outcomes that I expected everyone to get out of the session, but also for the GPHC exam, is understand your anatomy, okay? You also need to manage patients presenting with ENT problems. And you should also be able to recommend appropriate treatment options in relation to ENT-related complaints. So ear, nose, and throat. I'm going to go over some examples. So first of all, we've got otitis externa, which is an inflammation of the external portion. And then we've also got otitis media, which is an internal inflammation of the ear canal. So I'm just going to get this whole slide up. Apologies, quite a bit of clicking. So well, there's causative and there's infectious and non-infectious causes of otitis externa, a variety of causative factors that can be involved, and there's definitely various different treatment options, and when you've been referred depends on your symptoms that the patient presents with. So it's really important that you have an idea as to how you would go about treating this patient, okay? So we're going to go into a case study. So we've got, you're working in a community pharmacy and one of your regular customers brings in his child. Child is 8 years old and complains of ear pain. So what questions are you going to ask first of all? The following: which ear? How long for? Are there any associated symptoms? And do you have any known trauma? Is there any known trauma to the ear? And then here's the answer. The father tells you there is no known trauma. It's been for about 2 days. And the patient is complaining of pain, nothing else. And the temperature today is 38.7, okay? And you can, there's a picture. Now, obviously, not everybody can appreciate a picture of an ear canal, but you can see that there is a bit of swelling there, okay? So based on this presentation, what is your diagnosis? So it's an otitis media without effusion, okay? Now, apologies, I can't go through all the terminology with you, but there's different types of otitis media. Please get familiar with these and also be comfortable asking these questions in the over-the-counter setting. But obviously, recognize the sort of information that you will get in the exam. Obviously, this is a case study that's not necessarily going to come up in the exam, but there will be informations that might be put into a question which will help you decipher as to what diagnosis to lean towards. And treatment options, analgesia is recommended for the first 3 days. So actually, it's not a straightforward referral as such, but if the patient is complaining of pain, there's a temperature present, then we would refer because antibiotics may be needed, okay? And then red flags specifically for acute otitis media is number one, severe systemic infection. So think about your NEWS score. So that's a National Early Warning System score. If you don't know that, please look at it. Then second is signs of meningitis, mastoiditis, which is basically a swelling at the back of the ear, which would require a referral. Intracranial abscess, sinus thrombosis, or facial nerve paralysis. Again, these are things that you should be aware of because it would make a straightforward diagnosis very complicated and you would need to refer. Any children that are younger than 3 months of age with a temperature of 38 or more. Children 3 to 6 months of age with a temperature of 39 or more. So that's the sort of referral criteria that I need you to understand and need you to put into your head, specifically for the exam, but also just for in life as well. So we're going to move on to nose now. So we've got ear, nose, and throat here. So specifically for nose, epistaxis, which is nose bleeding. What sort of trauma or other common causes can be found? Obviously, trauma is right at the top, but there's other reasons. It could be because of infection. It could be because of dry skin, maybe because of high BP, medication, nasal polyps. So there's quite a few different causes for epistaxis. So again, differential diagnosis should always be playing in the back of your head. And then we've got different reasons for nasal congestion as well, for catarrh and rhinitis. So don't just limit yourself to one thing and one thing only, because there will be a variety of reasons why patients might have certain symptoms. So it's so important to ask these questions. And remember, treatment is based on the origin of your symptoms. There's no point giving someone decongestants when their nasal congestion is because of nasal polyps, okay? And then specifically with epistaxis, which is nose bleeding, certain red flags I would be putting into the back of my head would be hemodynamic compromise. So are they feeling lightheaded? Have they got a grey pallor to their skin? Are they feeling dizzy? Okay. Less than 2 years of age, facial pain or numbness, double vision, hearing loss, bleeding lasting longer than 10 to 15 minutes, any clotting abnormalities, any medication that they might be on. These are the sort of things that you should be aware of. Management-wise, acutely, we've got a method. Everyone kind of knows this from their first aid, but infection-associated causing can also cause this as well. So if it's due to infection-associated symptoms where there's crusting and then, it happens to be picked upon, then bleeding can happen. So Nazeptin is quite good for that. And alternative is mupirocin or nasal ointment, but again, these are not OTC remedies, they're prescription-only remedies. And then high BP or medication review as appropriate. So how would you know if someone has a high BP? If you had the facilities, you would check them in the pharmacy setting, and obviously you would have asked these questions before to know if they had high BP. So that is essentially what I had to say. Everyone's been a bit quiet in the chat, so do you guys have any questions in specific that you would like me to answer today? So please feel free to put them into the chat function, and I can do that just now for you. We've got about 20 minutes or so until the session finishes, so this is your time. If there's anything that you would like to ask me, you can do so. Either you could put it in the chat function, or you could unmute your mic and speak to me that way. Anything at all. It could be from any part of this, or anything that you might have seen in the recording. For the actual exams, would the pictures and the symptoms be rather straightforward or could they be confusing? I hope I've understood this question correctly. So, firstly, the GPHC exam is not there to catch you out, okay? As you can appreciate already, there are certain symptoms that overlap between conditions. Now, a key skill in a pharmacist is that they ask the right questions to be able to perform a differential diagnosis. Now, you should be comfortable asking those questions. You should already be thinking of certain diagnoses when a patient comes into your pharmacy. So, no, I would say that in terms of the exam, they will ask you questions which test your knowledge. Now, some of you will have learnt the basic, in which case it will rule out those people. Certain questions are designed to be a bit more complex and they are designed to test that knowledge. How far has this person gone into revising this specific topic? So I wouldn't say they're confusing. They might have subtle hints which try and direct you to the diagnoses. But if you just don't know, then you don't know. Okay, pictures wise, straightforward, but if you don't know what those pictures are, then not so straightforward. So I hope that that answers the question. I think those questions are your best questions, actually, where there are pictures involved. Very easy marks if you study the topic. So I hope that answers that question. All in all, do you guys feel comfortable? I know this is obviously just a drop-in session. I've not covered everything possible under the sun, but how do you guys feel a bit more confident, comfortable going into the exam with this knowledge? Obviously, this is not the end all and be all. You should be doing your own thing as well, but yeah. I think everyone is really. There will always be things you don't know, and that's what I went into the exam thinking about. There will just be things you don't know, and that's fine. Unfortunately, we are not, perfect, and there will be things that you just don't think about covering. But take an educated guess in those cases. There will be things that you can rule out. There will be things that you can take away from that. So don't just leave those questions blank. Take a guess at them because 50-50 chance you'll get it wrong or right. So take a guess. Any other questions at all? For those of you that watched the webinar before, did you guys find it helpful? Did you guys find it useful for your learning? Oh, great. That's fab. Hopefully my accent didn't throw you off. Um, amazing. And I failed to mention this, but in terms of drugs for raised intraocular pressure and what sort of drugs can exacerbate this, does anybody know what sort of drugs you would need to avoid in patients that might have glaucoma? What sort of drugs would you avoid recommending? Beta blockers? No, because beta blockers can be used in eye drops itself to help treat the condition. So anything else? Think about some of your drugs and their side effects. Steroids again. I guess you won't have that option in the pharmacy anyway, but again, prescribing decision rather than anything else. But think about over-the-counter drugs. What sort of things do you recommend over the counter which have side effects that include blurred vision, etc.? Amazing. Promethazine, stuff like that. So anything with an anticholinergic effect, okay? Anything with an anticholinergic effect, which would be drugs like cetirizine, loratadine, all those sorts of things possibly patients who have a raised intraocular pressure. So yeah, antihistamines, exactly. Cholinergic effects, basically, would be something that we would watch out for. So anticholinergics, any of that stuff would be things that you would want to be very careful about recommending yourself. So great, that's that question answered. And don't worry if you didn't know that. There are content in the BNF that would talk about this stuff as well. But obviously, you might see patients with these medications. It's more like a precaution, really. It's not a total contraindication, but obviously, if you're recommending yourself, you would be careful to put that out there. Any other questions at all? That's fine. You can ask me as I complete my slides. So we've got a few things going on with Pharmacy Foundation. So we've got a mock exam that you can sit anytime between the 20th of May and the 27th of June. Okay, so that is not available to everybody to sign up for that. I'm afraid I don't know the price itself, but if you go onto our website, you should be able to find out for yourself. But it's a full paper. You can sit at any time from between now and up until your exam. You can also access our live or on-demand feedback sessions as well. So that is something that will hopefully help you guys prepare for your exam if you haven't already done something like this before. So that is something that I would like to share with you. Similarly, if you're finding that you're a bit rusty on the calculation side, then we also do an online calculations masterclass. And again, I've done this masterclass myself when I was doing the exam, and it was absolutely amazing, hands down, something that really boosted my confidence going into that exam as well. And then, as I've mentioned already, we're on a variety of platforms. So we've got Instagram, we've got Facebook, we've got Twitter. So please, please, please feel free to get in touch with us at any point in that time. And obviously, it's important that you get the right support. So if there's anything directly that you would need to, ask about, then I think, yes, we also are doing one-to-one tutoring as well. So that's something that you can ask about as well if you find that you need a bit more help at the last run up to the exam. And that's essentially it from me. So I'm going to stop sharing now. And it's over to you guys. We've got another 10 minutes left. Do you guys have any questions that you would like answered at all? Any questions at all? Thank you so much. It's a pleasure, really. And one of you goes into that exam feeling confident, and you will feel confident. You just have to have faith. Obviously do your studying and don't worry, there will always be something you don't know. So don't worry about trying to cover everything. Just be confident in what you do know, and just have faith in yourself. It'll all be fine and you'll all come out qualified. I'm sure about that. So thank you so much. I think that's all questions answered. So I'm going to end this webinar, but obviously feel free to get in touch with Pharmacy Foundations, and if there's any questions at all, please just ask. And obviously good luck with your exam that's upcoming. So take care, have a nice rest of your Sunday afternoon. I know it's quite hard to find the motivation to do all this, but yeah, hopefully it pays off for you guys. So take care again, and I'll see you soon. Good luck. Bye.